Now is being recorded. Go on, Dr. Abdullah Hammuda.
Thank you, Dominic, for your introduction. And actually, I want to I thank GMI for this opportunity for inviting me to share my experience with my colleagues. Thank you, my colleagues, for your attendance today, and I hope this meeting will be of great value for all of us. Today, I will speak about clinical strategies in full mouth rehabilitation with dental implants. So that, because loss of teeth usually or always accompanied by loss of bone, supporting bone around. So that when we are going to make a full mouth rehabilitation for maxilla and mandible, we find that we not restore a normal tooth only. We find some challenges in our plans. For example, insufficient bone, loss of support for cheek and labial support, changing in the anatomical landmarks, and malocclusion. In addition to the remaining natural teeth, what to do? Sometimes it comes in malposition and in malocclusion. So the resorption of alveolar bone in maxilla make the alveolar ridge resolve to inside and superiorly. When we go to the alveolar bone loss in the mandible, so that the mandible move anteriorly, so that and laterally. Most of people with edentulous people complaining from class 3, or actually they are not true class 3, but the pattern of resorption and the pattern of functional rehabilitation to compensate for tooth loss. So that insufficient height or width of alveolar bone, in addition to the bone quality, make the challenging situation for implant and in oral for oral rehabilitation. Usually, always we start with the pre-surgical considerations. The pre-surgical considerations are start or hygiene, normal for all cases, mucosa characteristic, interarch space, arch form, bone quantity, and bone quality, assessment of bone quantity, bone quality, assessment of smile line, assessment of remaining natural teeth, assessment of the facial support, labial, cheek support, phonetics, tongue size and position, which is very important, in addition to jaw relationship. The anatomical variation consequently to the bone loss in maxilla and mandible is different, as we said before. And here we find the pattern of bone resorption and the classifications. We have a very many classifications about the bone resorption, which based on we work on the planning. Because the planning for this stage in bone loss different from this stage in bone loss. Consequently, bone possession, implant possession, consequently prosthetic restorations. So that the changing in alveolar ridge after extraction is the start from the modification of the normal treatment planning procedures. In addition, another challenge is the malocclusion. So that when we're talking about full mouth rehabilitation, you are reconstructing the occlusion from the first, because we don't have enough reference like partial dentures, so that you start to restart the occlusion reconstruction, occlusal plane reconstruction. First case with 60 years old patient, mandible partial edentulous with mild atrophied maxilla, completely edentulous atrophied maxilla. Here, when we see the combine CT, we find that in the mandible, the width and length or width and height for implant is possible to put an implant simply. When we look to the maxilla, we find also, I think we have enough bone width and height in most of the area of the maxilla, except for sinus pneumatization or lower height in maxillary sinus in the right side. In one another additional point is the interarch space. Interarch space is suitable to compensate for on the crown of the teeth, or we need to compensate for lost gingiva or missed gingiva. So in this case, with the normal occlusion, we need to restore the crown anatomical crown height, not more. We have, I think we have enough bone support, so that we put the implant with a very normal surgical phase, with flapless implant surgery in very simple way. To put the implant, we need to make some close the sinus lifting in the left maxillary left side and maxillary right side. We find here the septa in the sinus from the X-ray, and it's good luck to find the septa, because it increase your stability of the dental implant, so that putting the dental implant in the very normal way, restoring restoring the prosthetic part of the dental implant in the very normal way, using normal straight abutments, with optimizing the position of the finish line equigingiva in the posterior area, or maybe over the gingiva, supragingival finish line. Here you find in the cast and clinical photo with a very simple, straightforward. As you making no single tooth replacement or bridge tooth replacement, we make all mouth tooth replacement. The tricks here is in the surgery for sinus lifting and in the prosthetic workup, because you are constructing the bite registration. What is the method for reconstruction? This method, you know, when you do complete dentures, complete dentures, the same way you do occlusion blocks on special carrier, and make the patient and prepare the patient bite in resting position and the occlusion position, using a very simple abutment, straight abutment, maybe angle abutment, and we find here the restoration, fine restoration with the simple materials. I think it's the zircon. This photo is immediately post cementation. Immediately post cementation, you find there even the remaining cement here and here. We used in this case, I think multi-layer zircon or monoblock. we have two techniques of closed sinus lifting, using a stereotom technique, which is a classic way to make sinus lifting. And also we also additional way is using bone condensation technique with expanders to elevate sinus within 2 to 4 millimeter closed sinus elevation. Another case which is a female patient, 35 years old, partial dentulosum in mandible, atrophied maxilla, and partial edentulous atrophied maxilla. She has a bilateral bimaxillary protrusion. She has bimaxillary protrusion, impacted canines. The bimaxillary protrusion for this patient is congenital. It's from the origin. She has protruded maxilla and mandible, very resorbed arch form, very bad oral hygiene, very bad teeth remaining natural teeth. So when we plan for such case, we have many options to think about, especially do we restore the current occlusion, or we change the current occlusion? We have here to change the profile of the patient, so that we find a canine, impacted canine inside the panorama, or inside the CT, the radiograph for the patient. So the surgery will be somewhat complicated, so that we removed all badly mutilated teeth here in maxilla, removed the impacted canine, putting the implant in the proper position. In the proper position, putting the implant, then getting the implant stable in the proper position in maxilla and mandible, and then putting the graft around, and then close our wound, or our incisional wound, so that we find here this is the cross sections of the alveolar bone, how it is very thin. How can we put these implants here? The width here in some area is about 2 millimeter, 3 millimeter. To put an implant 3.7 or 4 millimeters, it's very difficult. Especially she has also an protruded maxilla and protruded mandible, so that the challenges in such case is severe proclination, class 3 malocclusion, and resolved hypoplastic maxilla. After the surgery, we make an alveoplasty in the first, remove badly mutilated teeth, and make an alveoplasty to adjust the contour of the maxilla, and then putting the implant in the proper position, and then reconstruct all around using a natural bone and alloplastic bone. You know, the bone that we cut in alveoplasty, we mix with alloplastic material, and then reconstruct the ridge again and covering by membranes, and then making. It was very important to make soft tissue release. It's very important to make soft tissue release around the implant to can cover the graft or implant without tension, because you have to keep the graft without pressure or without tension. After that, look to the arch form. It's completely different. We complete the arch form, we change the arch form, we change the patient profile after implant placement, and then you have to consider that we remain this natural teeth. We didn't remove. Why? You will see again. You will see in next slide why I didn't remove the natural teeth. Because how can I get this occlusion? I changed the profile. I changed the relationship. How can I restore the normal comfortable occlusion for the patient, so that I remain for the natural teeth. Also, I will talk about the remaining natural teeth at the end of this presentation. So that after that, you see the profile, you see after normal abutment, normal prosthetic options, seeming retained bridges, we restored such case with porcelain fused to metal. And look here for the profile before and profile after. Here is completely different. The profile before and the profile after is completely different. The arch form before and arch form after is completely different. And the smile is different. The issue that we did with the very thin alveolar bone, as we saw in this radiograph, look here for the bone width. Look here for the bone width all over the ridge. Along all the ridge, we have a very thin, very thin, very thin alveolar ridge. Sometimes, so that in this situation, we used bone splitting and expansion in another way to expand the implant, but in addition, we used bone grafting around. I will show the video for such procedure very soon. So that the advantage of splitting is cost-effective, reduce time treatment, and to conserve precious bone cells, eliminate difficult soft tissue closure, and restore labial contour. The splitting, we do the splitting in this way in the maxilla using lancet to cut in the maxilla and then expand the mandible with osteotomes, and after making the drills and then putting the implant. Sometimes we find the cracks, sometimes we find fracture of labial blade, so that we cover it with bone and membrane in addition. In maxilla, in mandible, because the bone is quite harder, we use disc or bezo in cutting the mandible, and we make a controlled expansion. I want to excuse me for just 1 minute.
Everything is okay?
Yes, everything is okay. Hearing me? Case 3 is another issue. We find such case occlusal plane is different because of long-standing one side functioning, so that we face here a very complicated and very challenging case. When we analyze the diagnosis for such case, we find that we found the challenges that we have are badly mutilated remaining teeth, severe occlusal canting, multiple infections, and periapical pathos associated with the remaining teeth, severe atrophy in the left side of the maxilla with severe atrophy in the right side of the maxilla. We have contralateral side. Here the case. When we find how it canting with the smiling, how that's the teeth here and alveolar bone is obvious in the right side maxilla and left side in the mandible. So we have many options in treating such case, starting with the records, in analyzing the record through computer software, and then optimizing how many millimeters we need to restore a normal occlusal plane and normal occlusal curve of Wilson and Munson. So after that, we decided to go to the simplest way in reconstruction this such case, which something useful for her age. So we start with alveoplasty, but in another level to optimize and adjust the occlusal plane, and then make an onlay graft. We use the implant that we got it from the alveoplasty, and then put it in the another side for onlay graft. We mix it with alloplast material and then with the graft, so that we need to make transposition to adjust the occlusal plane to normal occlusion level. And then after that, we look to the X-ray. It's a panoramic X-ray. Look for the bone grafts here. It's actually it increased and the normal level. And look here, we put the healing abutment, because healing abutment we make something like tinting to get the graft over the implant and to elevate the level. Actually, we didn't elevate the bone level completely, with remaining about 1 or 2 millimeters that we restored in another prosthetic way. Also, in such case we use normal prosthetic restoration with the normal abutments, semi-retained abutments, and look how the arch form changed and how we got a normal arch form, a normal abutment, and look for the height of the implant of the abutment here, which reflect you the height of the prosthesis. Look here, interocclusal distance, and here you find some steps from the prosthetic workup, because we have references to adjust the canting, because you need to adjust the canting from right side and left side to get normal function and normal way. After that, we make the patient on a provisional restoration for about 2 months, provisional restoration to get a normal function with the normal occlusal level and plan, and advices about the type of food and and how to use her mouth for mastication, and how to make rehabilitation for her muscles and masticator system. And then you find here at the end the final restoration of the patients, and final occlusion, which changed her life from before to after. How can now smile in very nice way. The steps in such case, in very simple way: alveoplasty in the right side of maxilla, only bone grafting in the left side of maxilla with inoculation of all periapical lesion, immediate implant placement, bite registration, and prosthetic restoration, which was a very complicated workup. And actually, we have many steps to reconstruct the normal occlusion and normal prosthetic way. Another case, which is a male patient, 55 years old, complaining from edentulous maxillary atrophy with partial edentulous in the mandible. He has a partial edentulous in the mandible, but actually here the challenge was in the maxillar atrophy. We face here some sort of severe maxillary atrophy, which in the quantity side and the quality side. They are in the quantity side and the quality side. So that we find you look here for the bone width. Look here for the sinus cavity. In normal way, here no sinus in the sinus membrane. Just even in the anterior region, in the second premolar or first premolar, or even in the canine, we don't have enough height and width for implant restoration. So that we go these challenges, and here starting with all minor surgical procedure, adjunctive surgical procedure in implant surgery used in such case. We make an open sinus lifting with a very small refined access, keeping the trapdoor buccal plate. And here I use in such case collagen, collagen block, collagen fleece, because it's in addition to bone, because it gives a good space and be stuck around the implant rather than grafts. And actually, I published a paper, I think 8 years ago, about that. I can send this paper for you, or can you access my scholarship scholar Google Scholar account or ResearchGate to get this paper. And then we put the implant in a very simple way, in very simple. Look here, it's a very simple. There is no enough bone to catch the implant. No enough bone to catch the implant. So to be careful, you have to be careful. You have to put the implant in a very simple way. Just we put the implant in as you see, supported with a very simple bone chips around, putting the graft in this side. In the premolar region and the canine, we used to make an splitting. We used to put a splitting to expand the ridge, because we have a very thin ridge. So that making splitting even inside in such way, and then making the implant placement in a splitted ridge. After that, completing bone reconstruction, graft inside the sinus, around the ridge. We put the graft, trying to restore the arch form and contour. Then making the membrane, putting the membrane And don't forget make the releasing incision, because the trick here is very, very difficult to close in tension. Look here, after releasing incision, we don't have it there. So that you allow for your bone and for your gap to heal perfectly after 6 months. After 6 months, in such case, I think it was 5 months and couple of weeks, we start the second stage surgery. Look, we're here to the implants after putting after insertion, and after 5 months and couple of weeks healing, you find here how the bone healing around the sinus, which was no bone. You remember here, the bone was very, very, very thin, about 1 millimeter to 0.22, 0.20 to 1.22. The bone height, which was not enough to fix the implant. Look here after that. Look here in this photo. Look after that how it's bone, and here it is immature bone. It will be matured. If we take this X-ray after 6 months, you will find all calcified bone in around the dental implant. Look here, for covering the apex here. The apex here is covered by bone callus or immature bone, maybe mature callus bone. So we start to make another options, because it was not valuable in this case to make an normal semi-retained prosthesis, because the ridge was atrophied. We don't have we don't have a labial or cheek support. You know, when we need labial and cheek support also. We're not restoring a normal crowns, but we're restoring, as we said, the function and facial aesthetics, so that we use the multi-unit abutments to make a hybrid prosthesis all over by screw retained, using weak and Invisalign materials on multi-unit abutments to restore such patient smile, which the patient change his smile and life, so that to revise or to conclude our conclusion in this presentation. So the pre-surgical preparation is pre-surgical consideration is a very important. Very important, starting from oral hygiene to the jaw relationship, to the many natural teeth, to the tongue site and position. Every point in patient screening is very important. Another issue, the key points you have is starting with selection of the dental implant prosthetic options, then the surgical techniques and tissue handling that you use, surgical technique and tissue handling, implant position instead of the graft, selecting the bone augmentation technique that you use. We can use, I'm a surgeon, we have many options of implant surgical bone grafts. You can do it, I can do it autogenous, I can make a graft from another area, but always we use the simplest way, the easiest way for healing, the simplest way on the patient, because the implant patient is different. Implant patient come to us to get a teeth, not to be subjected for a big surgical operations. Selecting of bone augmentation technique, enhancing osseointegration, selecting a bone augmenting technique, functional rehabilitation, and biomechanical consideration. This is all points that you have to consider in planning, and you have to consider in your implant workup. So that I will make a scanning for different points to details to get around. So from the starting prosthetic considerations to revise some points in prosthetic considerations, in biomechanical considerations, in consolidation of natural teeth, not you easily to get natural teeth, badly mutilated natural teeth, natural tooth out. No, please try to keep it. Why? Because it gets you the proprioception feedback mechanism. Dominic, I have just 2 minutes and I will finish my presentation.
Okay.
We
Okay.
have
Okay.
the preserving preoperative proprioception feedback mechanism, so that when I can keep a natural tooth or a natural teeth in remaining natural teeth, you have to keep it. You have to keep it because the sensibility of natural teeth, even if it was endodontically treated and restored, it's different than the implants. You consider enhancement of osseointegration using implant-related factor about surface area or surface treatment, about the bone, how to promote bone healing around dental implant using of graft type, and using of adjuvant surgery like laser or injections with the growth hormone, or some issues for enhancing osseointegration of dental implant, and selecting your prosthetic options that fit your idea in reconstruction or rehabilitation, which you have to think, I will restore the crown, or I will restore the crown of the part of the root, or I will restore the crown part of the root and soft tissue support around gingiva and tissue and lips, mucosa. You don't know. So you have to know first from the start if I will restore crown or crown part of the root or soft tissue or severe soft tissue support around, to select the prosthetic option and then go with your planning. We face some challenging cases, so that I want to share with you one of complicated case in rehabilitation. We used because this patient was subjected to resection surgery, and we use resection and construction of bone graft from iliac crest, and then implant placement in one session. And I published this paper in Egyptian journal, and we use here multi-unit abutment because I need a big surgical, a big prosthetic, a big prosthesis to reconstruct, to compensate for tissue support. So that I summarizing the key point: selection of dental implant, prosthetic option, surgical technique, tissue handling, implant position instead of grafting, selecting bone augmentation technique, enhancement of osseointegration, selecting bone augmentation technique, function rehabilitation, and biomechanical consideration. And we thank you for your attention, and I am ready for questions from you.
So thank you, Dr. Hammuda,
Yeah.
for this interesting seminar talking about full mouth rehabilitation with very important tips, recommendations. So now it's time for the audience to place some questions, to make some comments. Please, I strongly suggest you use the chat space here in the platform, down in the screen, because I can collect the questions and I can transmit them to Dr. Hammuda. I don't know if everybody has any question, or everybody would like to raise the hand and maybe make a direct question. I have one question. Ranul Sharma is asking about your opinion on title implants.
how can your opinion on tilted implants?
Tilt implant, sorry. Tilt, yes.
Yes, if you mean that we put a tilted implant, we have a precautions to and the criteria to put implant in a tilted position. We can put a tilted implant, especially if we use it in pterygoids or in another challenges, but you can use a tilted implant, but within 15 or 20 degree, not more, because more than it goes very stress around, except if you put all-on-4 protocol, because all-on-4 protocol we use a bar splinting all these implants, so that when put tilted with about up to 35 degree, you can compensate this 35 or 30 degree, you can compensate it with tilting, with compensating with the splint effect of the prosthesis from the right side to the left side, so that you can go with implant in the tilted way, but with a limitation. For a single tooth, maximum 20 degree. For all-on-4, maximum 30 or 35 degree.
Okay, I have a couple of comments. There is a comment from Dr. Abdullah El-Ghani Farag. I think you know him very well. I don't know if you can place the question here in the chat, otherwise we can comment it later on. Up to you. Just let me know. And then from Bridges iPhone is Sir, implant position according to prosthetic plan or according to bone present in alveolus?
Yes, it's a very good question. I appreciate you, doctor. It's a very good question. Actually, the ideal way is to put the implant according to your prosthetic restoration, and then may make a bone grafting or alveoplasty according to the bone situation or in the same situation. So that the first is to put the implant according to the prosthetic situation, but you have always some sort of the range. You move it. The range of prosthetic options that you play with the prosthetic options to reduce or to select the simple way in bone grafting, so that if you want to put the implant in the normal way, we maybe put it inside the mouth, but we need to put the implant according to the prosthetic options within the limitation of the normal bone. And then you decided if you do a big bone grafting or the simple bone grafting. And I think in all cases that I presented in this presentation, it was obvious that I am trying to compromise between the prosthetic option that I use and the bone conversion.
Okay, I have another question from Raul Sharma. What's your comment on basal implants?
Look, basal implant. When the basal implant was invented and introduced, the basal implant it's a transitional implant. You know, you cannot make a soft tissue support around. You cannot make a hygienic with the basal implant. Basal implant is a temporary restoration, not a final restoration. You cannot keep a long-term hygienic prosthesis around the basal implant. You know, basal implant is a long, very long implant, very and thin implant, and just you put in the bone and put the reconstruction. How can you make the profiles and hygienic soft tissue around dental implant? How can you cannot a basal implant in every area in the patient mouth? It is just has a limited situations. So that basal implant you can use it, but in its indicated cases.
I have another question comment from SP. I'm sorry, I don't see the complete name. Can you present any of your case done using tilted implant technique in pterygoid region and any tip on placing implant in pterygoid region or maxillary tuberosity region in an atrophied ridge?
Yes, I have a lot of cases like that, and even with zygomatic implants, but we can make it in another presentation. I promise to make, because full mouth rehabilitation is we cannot cover in just one lecture. It's a sequence. It's a big topic. I just concentrate in this surgery, in this presentation, on some points in planning. I will show you in next presentation, or we can make some share after this lecture, because I need to look for in my cases in the computer. Maybe next lecture.
I mean, maybe what we can do is you can provide an additional information. We can simply share it with the attendants when while we are going to send the link for downloading this presentation. We can add some cases, or up to you. You can send it to me and we will do it. Okay. We will annex, okay?
Okay.
I have another question from Brigitte. Sir, how to prevent crestal bone loss implant should be, Sir, how to prevent crestal bone loss implant should be submerged 1 millimeter always?
No, doctor. Please don't submerge the implant 1 millimeter always. Just use the implant in a crestal position, even except if you use the top treated implant and you have to use a healing abutment. So that to prevent crestal bone loss, you have to consider implant position and biomechanical considerations and less invasive surgery to keep the bone. These issues reduce the crestal bone loss. Even after that, in the prosthetic options, you have to keep the finish line away from a crystal with the implant. You have to give it you have to respect, actually. You have to respect the emergency profile. You have to respect the emergency profile. You have to respect the soft tissue space around the neck, around the connection between implant and abutment. You can use the platform switching always that we find in implants today, the platform switching. But when you use implant that treated from the top, so that you can submerge, not to prevent the crestal bone loss, but because the bone jump on the top of the implant to give the space all over. But you have to put a healing abutment, special healing abutment for that issue.
So in fact, Dr. Aftab Mirza replied to this question saying simply no. So it's implants should be 1 millimeter always. He said, or she, sorry, no.
I agree with you, Dr. Aftab, except for the treated implant from the top, because this is a recommendation of the manufacturer.
Okay, any other question, any other comment, please? Take the opportunity.
Yeah, this is Dr. Amrendra, and I will thank you, Mr. Dominic and Dr. Abdullah, for the nice presentation from GMI India. And there's one query, Doc, that I would like to know that you have told that you can mix the matured implants, I mean, to natural teeth with the implants. But in some studies, it is suggested that the natural tooth has the PDL fibers attachment, the proprioception and the mechanism. So do you advise to mix the natural teeth with the implants in the long run? What is your opinion about that?
Okay. Actually, mixing a natural bone graft with the implant, with the bone graft, you mean that?
No. I mean to say natural teeth with the implant.
No, you don't connect natural tooth with the implants. Don't connect. Always they are separated. I mean that you can keep some natural teeth for adjustment of occlusion, for proprioception, for natural feeling of food and during mastication. I just say to keep it, but don't ever connect natural tooth with a dental implant.
And about the submergence of, suppose we have the GMF frontier and GMF elegant implants. So GMF frontier, you mean to say we can't submerge even 0.2 mm to prevent the crystal bone loss in the long run? Because in some studies indicated that we can submerge around 0.1 to 0.2 mm to prevent crystal bone loss in the long run, especially for the frontier implants.
No, these are very old studies. At the moment, regarding frontier implants, you are just put it in the platform, on the crystal platform. This is regarding frontier implants. If you're working with avant-garde, you have to submerge about 0.5 millimeter. For every implant, according to the platform design, you have the instructions to put it the implant, because according to the platform, you find the emergency profile, the biological width that you respect, the biological width around the dental, the neck of the dental implant is a very important to consider. So that, for example, for frontier implant, you have the biological width, we have machined collar with platform connection, so that it is enough to put the implant on the bone crest. For avant-garde, the situation is, the design is different, because the treatment is in over and the biological width we change it to be inside, because the abutment also is different in design. So you can submerge the implant about 0.5 millimeter. And if you submerge the implant 0.5 millimeter and you make an X-ray after 6 months, you will find the implant 1 millimeter more, because the implant is, the bone is growing on. So that you have to put, if you submerge, you have to put healing abutment all over to create the biological width in the normal way. I can't hear you. I can't hear you.
Yeah, I would like to know your view on immediate loading in case of frontier implants. Do you advise immediate loading or delayed loading, or maybe functional or non-functional loading in case of all on 4 on all on 6 in frontier implant? What is your opinion about that?
Okay, I say something. It is not at the moment. We have a very much evidence-based study about immediate loading, so that if the case was indicated, go for immediate loading. It's normal. But if you ask me which is better for bone healing, which is better for prosthetic options, which is better for soft tissue, which is always delayed loading is better from biological points of view. But immediate loading today is a normal treat option, but you have to always inform the patient we have 10% risk, because I cannot make immediate loading either routine dental treatment and dental implant treatment, because I cannot control the patient force. You cannot control the patient quality, bone quality. You cannot control. So that if you ask about the implant, no, I said you implant, you have a very good implant design, mechanical design, thread design, and surface treatment that enable you to use it in immediate loading, but within immediate loading rules, so that not I am when I advise my colleagues not to start with your practice with immediate loading. You have to understand the biology of bone and biomechanics in mastication. If you understand that, go for immediate loading. If you can control patient force during mastication from opposing occlusion, patient muscles, habits, if you can control the crowns, go for immediate loading. No problem. If you can, if you get, if you can, if you be confident from bone quantity, bone quality and bone density, the capacity for healing, go for it. No problem.
Okay. And suppose if
Always,
you talk,
always you have 10% risk. Always immediate loading, you have 10% risk.
and suppose if we talk about bone quality, and suppose the bone is D3 or D4, or the bone is D1 or D2, and suppose in D3 or D4 you got a good torque, if suppose about 50. So if the bone quality is D3 or D4, but the torque is around 50 plus, in that cases, what is your advice to go for functional or non-functional loading?
Look, for bone quality D4, don't go ever for immediate loading, especially if, except if you have a splinted prosthesis, like Olin 6 for maxilla. But the torque is not always the judge, because we can have a good torque, but labial plate was completely lost, so that not always we consider the torque stability, but it is standard. Your question about to go to the functional or non-functional loading, actually, for when you go to the non-functional loading, after a while it will be functional, because footballers come around. If opposing what natural teeth, it will be overlap. So there is nothing say non-functional. Immediate loading means functional. The issue is that is a progressive or complete or no. So the optimum concept is light occlusion, which is functional occlusion. We don't have actually on the reality, there is nothing to say non-functional. Even if you have healing abutment submerged, non-submerged healing abutment over, you put the implant under function. The optimum is light occlusion.
Thanks.
Thanks for you.
Okay, I don't know if there is any other question. I have received many people leaving saying thank you, Dr. Hammuda, very good presentations. I've seen some comments. I don't know if there is another question, any other comment. People is saying thanks. Business is saying thanks, and I don't know if there is any other question. Take advantage of this opportunity to ask Dr. Hammuda. So, okay, if there are no more questions, we can finish here. I just want to remind you that you are going to receive by email the link to download this presentation, the video of this presentation, so you will receive this webinar recorded. And if there is any document that can be shared by Dr. Hammuda, we will send it as well. So I don't know if you want to say anything else, Dr. Hammuda.
Hoping to see you soon. Actually, I appreciate, and I have to thank GMI for this opportunity for you, my colleagues, and I hope to share our experience. And may we meet again very soon to share, to be more reactive, especially in, I hope to have live events. It will be better.
we will organize it. So thank you to all the participants, the attendants. Thank you for registering. This is the first of our new English sessions. Please stay tuned, because we are going to promote and to invite you for more sessions also in English. Thank you very much to all of you. Have a nice day, and thank you again, Dr. Hammuda, for your.
Thank you, Dominic. Thank you very much for your effort and everything. Thank you.
Okay. Bye bye, everybody. Ciao. Bye bye.
Bye-bye.